All right, let's get right into it and talk about thymoglobulin. If you're a pharmacist working in transplant, you know how crucial it is to have a rock-solid understanding of this drug. It's a powerhouse, and we need to know its ins and outs. So here's how we're going to break this down, kind of following a real-world clinical workflow. We'll start with the fundamentals. What is this stuff? Then we'll jump into the real practical details of dosing and administration. After that, we'll cover the super important safety monitoring and dose changes you'll be making. And finally, we'll look at the data that shows why it's so effective.
Okay, first things first. Before we can use it, we have to know exactly what we're dealing with. So what is thymoglobulin at its core?
So here's the biggest takeaway. This is not a single targeted monoclonal antibody. It's polyclonal. We're basically getting a whole cocktail of different antibodies from rabbits that have been exposed to human T cells. And why is that so important? Well, it means the drug can hit multiple targets on those T lymphocytes, giving you a really broad and powerful immunosuppressive effect.
In the world of kidney transplants, it has two main jobs. You can use it upfront to prevent acute rejection, especially in high-risk patients. Or you can use it as a rescue therapy to treat an active rejection that's already happening. But remember, and this is key, it's never used alone. It's always going to be one part of a larger immunosuppressive cocktail. Okay, so that's the what. Now let's get into the how. This is the practical, hands-on stuff where your role as a pharmacist is absolutely essential.
The good news is the daily dose is pretty straightforward. It's 1.5 milligrams per kilogram, whether you're preventing or treating. The main difference is just how long you give it. For prevention, you're usually looking at a shorter course, about 4 to 7 days. But if you're treating an active rejection, you'll need a longer run, somewhere in that 7 to 14-day range.
Now this right here, this is a non-negotiable step. Every single time. You're almost guaranteed to see some kind of infusion reaction, and it's mostly driven by cytokine release. So to get ahead of that, you have to make sure the patient is pre-medicated with steroids, acetaminophen, and an antihistamine about an hour before that infusion starts.
For reconstitution, the details really matter. You're going to use exactly 5 mLs of sterile water for each 25 milligram vial. And remember, gentle rotation, never shake it. Then you'll transfer that into your final bag. The easy rule of thumb to remember is for every 1 vial you use, you need 50 mLs of infusion solution. Okay, this is a huge safety point, so pay close attention here. That very first dose has the biggest risk of a bad infusion reaction. That's why you have to run it in slowly, over at least 6 hours. After the patient gets through that first dose, you can speed it up a little bit for the next ones, but still run it over a minimum of 4 hours. And to wrap up administration, just a few final critical checks. This has to be given in the hospital under close supervision. Always use a 0.22 micron filter. And because there are no preservatives in this stuff, once you mix it, you have to use it right away. All right, let's switch gears to monitoring. And this is where you, as the pharmacist, are going to be so crucial. We're talking about watching those labs and making dose adjustments to keep the patient safe. So the big question is, how do you know when it's time to step in and make a change? Well, the answer is right there in the daily CBC. You have got to be looking at a complete blood count every single day the patient is getting this therapy. And the guidelines on this are super clear, which is great. If you see the white blood cells or the platelets drift down into that moderate range, you cut the dose in half. Simple as that. Now, if they really bottom out and hit that severe range, you've got to raise the alarm and seriously consider stopping the drug altogether. This is a daily safety check you'll be on top of.
So, beyond those daily blood counts, there are a few other big picture warnings that the whole team needs to be watching out for.
I mean, look, the black box warning really tells the whole story here. This is a serious drug. It's not something to be used lightly, and its powerful effects on the immune system mean it has to be managed by clinicians who really know what they're doing in transplant medicine. So let's break down these big risks. You've got the immediate stuff that can happen during the infusion, like anaphylaxis or that cytokine release syndrome. Then there's the ongoing, major risk of infection. This is why things like CMV prophylaxis are so important for these patients. And thinking longer term, you have to be mindful of a higher risk for cancer and make sure you counsel patients to avoid any live vaccines. Okay, so we've talked about the potential risks, but what are you actually likely to see day to day? Let's take a look at what the clinical trials tell us about the most common side effects. And wow, this chart right here, it just hammers home why that daily blood count monitoring is so critical. Look at that difference. 63% of patients on thymoglobulin had low white blood cell counts. That's more than 4 times higher than the other group. It's an expected effect, for sure, but it's exactly why those dose modification rules are in place.
And here's that classic picture of an infusion reaction. You know, the fever, the chills, feeling sick to your stomach, headaches, all that stuff is really common in the first day or so. This whole list just screams pre-medicate. It's the best way to keep your patient safe and comfortable. So you might be thinking, with all these risks and side effects we just talked about, why is thymoglobulin such a go-to drug? Well, it all comes down to the clinical evidence. It works, and it works really well.
And this graph, this is everything. This is the why. Just look at that plunge. Within a single day of starting treatment, the patient's T cells are basically wiped out of circulation. That right there is the powerful immunosuppressive punch that makes this drug so effective. So, what does that T cell knockdown actually do for the patient? Well, here are the results. In a big study looking at preventing rejection, the rate of treatment failure, which includes rejection, losing the kidney, or death, was way lower with thymoglobulin. We're talking 25% versus 38%. That's a huge difference.
And what about for treating an active rejection? The numbers are just as impressive. A major U.S. trial showed a 78% success rate in turning around an acute rejection. It confirms just how powerful this therapy is when you really need it.
So, what's the big takeaway here? At the end of the day, thymoglobulin is an amazing tool because it's so incredibly powerful. Our job as pharmacists is all about balancing that power. It means we have to be on top of our monitoring, but it also means we need to think ahead. We have to be proactive with things like anti-infectives to anticipate the risks and do everything we can to keep our patients safe while this drug does its work.